the cervical thoracic junction, basically T1, T2, maybe T3, rib 1, rib 2, maybe rib 3. The lower you go in the spine, you start losing leverage, and so the technique doesn't work the lower you go. So it's really for that thoracic cervical junction. You can do the technique, I tend to do the technique, either side from the same side, or you can walk around the table and I will show you how to do, one or the other. I'm also going to demonstrate just a couple other things in relationship to just some soft tissue stretching for the lumbosacral region, as well as some stretching for the cervical thoracic region, which takes into account the particular technique that we're going to do today. So when you do your palpation and you get your sense of what's kind of going on with the patient's prone, again, this is the cervical thoracic junction. Sometimes you can potentially get that, vertebral prominence, and if you go with statistics, that's C7, so the one underneath is going to be T1. If you're using this technique to correct a vertebral problem, then your contact is going to be closer onto the transverse process. If you're using it to correct a rib, then you're going to go a little bit more lateral, so you're on the rib head. You don't want to go too far lateral so that you're like on the rib body or on the rib angle. So you want to get that kind of rib head, and or if you're going to get the vertebra on the TP. Now, obviously, the TP and the rib head are together, so you really get one, you get the other. It's kind of a specificity point in relationship to what's your intention in terms of the contact. Also, remembering that the entire upper extremity attaches to the spine indirectly through the clavicle and then through the first rib. So the first rib type technique, and this technique can be very helpful for stresses that accumulate just for upper extremity issues. And again, the cervical thoracic junction, for what things that we talked about in the class, because the facets are slightly variant. The lower facets of C7 modify to accommodate the upper facets of T1 or vice versa, so there is some stress that's there. It's also somewhat a technically difficult area to get to. Also, when I do this technique, I affectionately call it the disco move, which I'll describe why and like that. Although you won't find the disco move if you Google it. You might get like Saturday Night Fever or something. So, when you want to kind of come up and do the model. And then also on the board there behind Dr. Heath are the things that we're going over today. So if you want to take a picture of that so you kind of know what the expectations are, because next week when we start with the cervical spine, that's going to get erased. There'll be a whole new set of stuff there. Okay. So when you do this particular technique, you want to have the headpiece, if possible, down a little bit of deflection so that accommodates cervical flexion. For the most part, all the techniques that we're going to learn accommodate cervical flexion. So if a person is prone, it's going to be like this. If they're supine, then it's going to be opposite, right? Their head should be, kind of a little more upwards. So in terms of being able to palpate this area, as I mentioned, obviously it would be easier in a clinical situation if they had a gown on and or no shirt on, kind of a thing, so you can kind of see more easily. But because if you find and you come up and say, well, there feels like that's the big one, but that's probably like C7, so that puts you in the ballpark, right? And sometimes, again, just to kind of repeat, using 2 fingers on either side of the spinous in a repeating fashion, particularly in this upper region, you can got to get some sense of, is there a rotation with an accompanied posteriority? Would there potentially be a variance in the spacing between the spinous processes? And then also to be able to feel the ribs in particular, you can either come out a little bit more laterally, or sometimes I just tend to use 2 hands because that's a little more further out. Or for the first rib, you can be kind of right on top and kind of, go in a circular kind of pattern or fashion. You can be able to feel them, and sometimes you can kind of put pressure kind of like this, and then you can feel mobility, all right? And if it feels fixated, that gives you information, and or if a patient says, yes, that's sensitive or not, that can give you information that this could be a level where there's a lesion. Usually if something feels kind of funny, but the person says it doesn't bother them, it may be kind of a couple of anatomical variance and not significant. But so to be able to, and I'll explain what no scissoring means here in a second. But let me just show you some of these other stretches. In the lumbosacral region, either pre or post manipulation, or sometimes even instead of manipulation, one of the things that you can do is you can reach around and grab the ASIS with one hand. I'm going to use the heel of my palm or my pisiform, the ipsilateral side of the spinous process. And this hand is going to push or pull towards me this way. This hand is going to push away. So what I can do is create a kind of a traction. Sometimes you might get a little bit of a release when you do this, and that just kind of helps. And then I would come over to the other side, kind of repeat that on this side.
And you're looking for a release?
This is, yeah, this is more soft tissue stuff, just to kind of, start to loosen somebody up.
Gotcha.
And then you get, some sense of, is there tension, what's the tolerance that the patient has for, these kind of movements and so on and so forth. Another thing that you can do in the musculature, particularly the erector spinae group at this level, you can do what would be kind of a modified covered thumb kind of thing. I just put my hand like this, and then just cover it with my palmar area, and just kind of with pressure, not really, I guess you can kind of call it a bit of a thrust, but mostly just pressure going and slightly caught at. You can come all the way up the spine with this. And this just gets more specifically, pressure on the vertebral levels. And again, this is just soft tissue stuff that, quite often I would do pre-manipulation. It just helps to loosen up your patient. So that's not text or test material. It's just adding to your knowledge base. So you can do something similar in the cervical thoracic junction, which is going to be very similar to the manipulative technique. I'll show you that first. So what you want to be able to do, your contact hand is going to be the tabled hand. So this is the hand that's closest to the table. Again, I would palpate and find either the level that's rotated. So this particular technique is good for a rotation, more than for a flexion extension problem. If it was that, then I would do either this or this. I mean, I could kind of do uniform if I wanted to, but you get a little bit more specificity and I guess, potency with this particular technique. And you can see that I'm slightly forward in my stance, and that my hand is coming back this way. So to be able to accommodate that angle, because remember, in the upper thoracics, our level of correction is back this way, right? It's going from superior to inferior. So this is the way that you can accommodate it by standing forward. One of the things that you have to kind of think about when you do this technique is Velcro. Because what you're going to do is you're going to take your slack still in a superior direction. And if I want to be on the vertebra, I'm going to be closer to the vertebrae this way. If I want to be on the rib, I'm out a little bit further. But one of the things you want to avoid is kind of that kind of stuff. So you just have to kind of think Velcro. So in this case, this is going to be really more vertebral. So this hand comes in here like this, and I'm pushing down. Now you can see that I'm using a fair amount of pressure even before I taking out the slack. So one of the things that we're going to do in learning this technique is the important thing is to be able to learn how to drop your body. You can see how Simon's whole thoracic area is being kind of forced down. So your elbow is straight. Students always do things that I can't reproduce because they're just wrong. So a lot of times what students they kind of do this. Because they don't want to do it or they don't know what they're doing. So it's important just to kind of realize that that's what you want to be able to accommodate. To be able to accommodate that, your hips kind of rotate a little bit, particularly when you're on the same side. So that's why I call it the disco move. So the other hand, which is the indifferent hand, is going to come out like an L. And so this allows me to put my thumb in the suboccipital ridge and my index finger over the parietal area. Now the rest of my fingers, when I do this technique, really aren't involved so much. But I have seen people just put their whole hand on somebody's scalp. But my suggestion is not to come up here and do it, because then you can slide off and scalp somebody. So it's always important to use your thumb to create that leverage in that suboccipital area. And then you kind of make a C here more than a straight-on L so you don't pinch their ear. All right? Now, the idea is that I'm going to take my slack from inferior to superior this way. I'm on the level that's on the lesion. This hand comes around. And then I'm going to rotate him away. I'm going to rotate him towards me and laterally bend him away from me. What? So you can see he's being laterally bent away from me. Yeah. He's starting to turn and look at me, right? So he's rotating towards me. Until I feel like right there, I've rotated him and laterally bent him enough to lock out at that particular level. Remember, manipulation is all about locking out.
So you go as far as you can until you can't go any further.
Yeah, until you feel like it's locked out. Like here he's not locked out. Probably over here, he's like even past being locked out, or the lockout is down here somewhere, not really where you want it to be, and like that. And so slack comes out. Sometimes I can kind of do a little bit of this, and then make my correction like that. So the don't scissor part is to avoid doing this. throwing his head around. Or leaving this hand straight and just whipping his head. I've seen people do that. It's not necessarily that it's wrong. It's just not necessarily that it's right. And if you do it on the final exam, you're going to get points taken off. So don't do that. One of the things that it facilitates is more power, because you have more leverage. And if you don't know how to control your power, you can hurt somebody. So my suggestion is to make this your thrusting or contact hand, so the thrust comes through this, while this is just stabilizing. Although I do have to admit there are times when I will kind of get there and add this a little bit to get a little bit more like, boop, punch to the power. But after 30 years, I'm pretty good about knowing how to do that and when to do that, so I don't jack somebody up. So it's not a good thing, first of all, to learn how to do that technique that way. So now if I want to do the other side, and like I mentioned, I do it from the same side, then I'm going to cross over so it's my non-tabled hand that makes my contact. This other hand comes around and does much the same thing, so it's like that. And then my thrust is back again this way. When I do that particular correction, I'm not quite as disco-y. But if I wanted to do that correction, I would come around to the same side. This is another option. I tend not to do it because you'll find when you get into clinical practice, if you can save a few seconds, instead of having to walk around the table or reproduce or repeat tests, like do this test, sit down, now do this test, stand up, now do this test, lie down, now do this test, turn over, now do this test, stand up. It's not efficient. But it would be the same kind of thing in doing the test that way, or the correction that way, okay? So you can learn how to do it, both sides from the same side, or learn how to do it, one side to one side. Either way is fine. Even on the test, if you say, I'd like to do it from the same side, that's fine. I want to come around to the other side, that's fine as well. We're certainly able to appreciate your technique. So the stretchy part, which is a couple or complementary to what we did down here, right? This kind of stretchy thing. You could do something similar in this area, where instead of adding a thrust, you just kind of separate, a little bit of stretch, a little bit of stretch. Y'all see how I'm doing that? So this is not really this is just soft tissue stuff. The other thing that you can do in this area to help, and sometimes you can do the same side or you can cross over. This hand is going to go this way, this hand is going to go that way, right? So I'm just doing some basic stretchy stuff. So the stretchy stuff is helpful before you do the manipulation because it makes the soft tissues begin to relax a little bit, and then that makes the articular tissues a little bit more, willing to release. So these are great prep things. I'm not going to necessarily ask you to prep things on the test. I wanted to demonstrate them to you so you can learn how to do them. All right. So we're going to practice this up for a little while, and then we're going to